Respected chairpersons, my dear teachers, seniors, and friends, thank you for the invitation to Thrissur. Kiran and I, he was our first DMPG, and I was assistant professor at that time. 2014, he joined. Both of us don't know dance, so we were not dancing like this, but we used to have a lot of good time together. And I thank you, Kiran, for this invitation. And I'm also happy to see that you are continuing the good friendship and relation with Manikandan sir, very nice human being. So thanks to Manikandan sir also. So going on to the topic, the great thinker Voltaire said that a man has to be judged by his questions rather than his answers. Probably this rule would apply to the evaluation of a drug also, as in this case the NOACs. So we would be trying to find out what are NOACs, why exactly are they required, when should we use them in clinical practice, and which one to choose. And if we decide to use one for any indication, how to prescribe it to the right patient, and most importantly, when not to use it. So we'll try to find out these. And this ultimately brings us to the topic of the rational use of NOAC. WHO said that the rational use means that using the right drug at the right dose by the right route at the right time for the right patient. And they also added that it should be at the lowest cost to the patient and the community. So what exactly are NOACs? We know that the coagulation pathway which we used to memorize from our MBBS days, the intrinsic and the extrinsic pathways. And we have warfarin, the age-old agent, and the vitamin K antagonist which acts on the factors 2, 7, 9, and 10. So over the course of the last few decades, things have changed. Vitamin K antagonists reduced stroke in AF. It was an important finding. Then dabigatran came, rivaroxaban and apixaban came, and they were thought to be at least as effective as vitamin K antagonists. And finally, in the current era, now NOACs are considered to be safer and slightly more effective compared to vitamin K antagonists, and they are now preferred. So essentially, we have two kinds of NOACs. One is the direct thrombin inhibitor, dabigatran. The other is the factor 10 inhibitor, which includes apixaban, rivaroxaban, and edoxaban. The first two are available in India. So dabigatran is an oral direct thrombin inhibitor. The standard doses are 150 mg twice daily and 110 mg twice daily, especially if the patient's age is above 75 years, there is concomitant use of verapamil, and if there is increased risk of GI bleed. There is also a smaller dose of 75 mg BID, which is less commonly used. The major trial was RELY, which found that using 110 mg BD compared to warfarin produced similar rates of stroke with lesser bleeding, while using 150 mg twice daily compared with warfarin produced similar bleed but with better stroke reduction. The second molecule is rivaroxaban. I would say probably the most versatile because there are so many doses and so many indications. It is the only NOAC which can be used as an once daily preparation. The standard dose is 20 mg once daily. There are also various other confusing formulations with 15 mg OD dose, 15 mg BD dose, 10 mg OD, and also the 2.5 mg twice daily vascular dose, which we'll come to later. The major trial was the ROCKET trial. There was no difference in the risk of bleeding, while intracranial and fatal bleeding occurred less frequently with rivaroxaban. The third important agent is apixaban, which is again used in a standard dose of 5 mg twice daily. The 2.5 mg twice daily lower dose is used if 2 out of 3 criteria are fulfilled. One is age more than 80 years, weight less than 60 kilograms, and creatinine of more than 1.5. So why do we need NOACs when we had warfarin, the greatest agent of all time, and why exactly should we change? Because we know that old may not always be gold, and there are two major issues with vitamin K antagonists, one being erratic INR values and unreliable time in therapeutic range. And we also find that the time to peak activity is more for warfarin, taking 3 to 4 days, while all the other agents start their effect within few hours, which makes management of AF and thromboembolism very convenient for us, even in the outpatient setting. So when to use? We have standard indications, which are atrial fibrillation and prevention and treatment of venous thromboembolism, including both deep vein thrombosis and pulmonary embolism. Newer indications are the vascular indications, which are used in CAD and peripheral arterial disease, and we have some evolving indications like use in LV clot, chronic thromboembolic pulmonary arterial hypertension, and doubtful use in APLA syndromes. Of course, we have been using these agents right, left, and center as we dealt with COVID, because clot was part of the plot in COVID. So in practice, we choose NOAC when there is a clear, strong indication, when the patient can afford it offers convenience, and when there is the patient is less likely to monitor INR promptly. This is data from our own state. Many of the authors are sitting here, my teachers and seniors. The use of NOAC when this data was collected was actually very low, but now with more NOACs being available at more affordable cost, more and more patients are being prescribed in Kerala. So much so that almost all specialties, not only medical but also surgical specialties, are also using, which makes it even more important for us to use these molecules responsibly in the right dose for the right patient. So in AF, when somebody has to be started on OSE, now the guidelines say that NOAC is preferred over a vitamin K antagonist. But we should use it only in non-valvular AF, which means AF occurs in the setting of absence of a mechanical prosthetic heart valve and in the absence of significant mitral stenosis, which is usually rheumatic in our country. But at the same time, it means that NOACs can be used in patients with mitral regurgitation, AS, AR, and also in bioprosthetic valves and valve repair surgery after 3 to 6 months of treatment with a vitamin K antagonist. In hypertrophic cardiomyopathy, again, NOACs can be safely used, and in venous thromboembolism, NOACs are preferred over vitamin K antagonists. There are some special doses when we use it for DVT and pulmonary embolism in the acute management. The most common drug used is rivaroxaban. So standard AF dose is 20 milligram once daily, but in acute treatment of DVT or pulmonary embolism, the dose is higher for the first 3 weeks. It is 15 milligram twice daily for 3 weeks, followed by standard 20 milligram OD. For apixaban, again, the double dose is used for 1 week, that is 10 milligram twice daily for 7 days, followed by the standard 5 milligram twice daily dose. For long-term prophylaxis, the lower doses are used, apixaban 2.5 mg BD and rivaroxaban 10 mg OD. In post-major orthopedic surgery to prevent venous thromboembolism, the lower doses, 2.5 mg apixaban BD, 10 mg OD of rivaroxaban or OD dose of dabigatran can be used. In patients with atrial fibrillation along with coronary artery disease who have undergone PCI, they need antiplatelets also. We should remember that we have to minimize the duration of dual antiplatelet therapy along with an oral anticoagulant because the bleeding risk is increased. So if we are using a NOAC along with a single antiplatelet, the preferred antiplatelet agent is clopidogrel. So it is better to avoid ticagrelor and prasugrel when we use NOACs. In patients with chronic coronary syndrome and coronary artery disease who have high-risk features, and also in symptomatic peripheral arterial disease, vascular dose of rivaroxaban of 2.5 milligram twice daily, along with a single antiplatelet, usually aspirin, is preferred. In patients with cancer, conventionally the LMWH was preferred, but now the latest guidelines mention that NOACs are the preferred over low molecular weight heparin over vitamin K antagonists. One word of caution is in luminal GI malignancies, where rivaroxaban has to be less preferred because there is increased risk of GI bleed. Now, how to use? There are various guidelines. The most important one is the 2021 European guideline. A few points from that. The oral bioavailability of rivaroxaban is 66% without food, and it increases to 100% with food. So rivaroxaban is the only NOAC where there is a mandatory recommendation that it should be taken along with the major meal of the day, usually which is lunch in our part of the country. So rivaroxaban has to be taken along with food. And on each follow-up visit, we have to reconfirm the indication and contraindication, check whether the patient has any bleeding, check the hemoglobin, and assess the renal function and the creatinine clearance. All NOACs are contraindicated if the EGFR, creatinine clearance, is less than 15. For dabigatran, if the EGFR is less than 50, it is preferable to use 110 milligram twice daily. If the creatinine clearance is between 15 to 50, a lower dose of rivaroxaban, that is 15 milligram, has to be used. And apixaban, we have already mentioned the indications. This is because dabigatran has got the maximal renal excretion of 80%, and apixaban is probably the safest in patients with renal dysfunction because its renal excretion is only 27%. So much so that in patients with CKD on hemodialysis, people are now trying NOACs. The FDA has given a cautious extension of apixaban use, but we should not make it a routine practice. What about chronic liver disease? In child A, normal dose can be used. In child C, we should not use NOACs. Child B, we have to individualize. What about a concern in elderly? Do we expose them to higher bleeding risk? All the major trials, the median age, mean age has been above 70 years, so it is relatively safe. And OAC use and adherence has increased in the elderly population with the availability of these NOACs. Very, very important, we have to assess the fall risk in elderly patients when we prescribe, because fall and trauma in a patient on NOAC can be catastrophic. NOACs at extremes of weights, that is weight less than 60 kilogram and more than morbid obesity with more than 120, they may be less reliable, and in such situations VKA may be preferred. In thrombocytopenia, if it is less than 20,000, absolutely contraindicated. If it is more than 50,000, based on the relative risk and benefit, we can prescribe. What about LV clot? Meta-analysis show that vitamin K antagonists are better compared to NOACs in post-MI with LV clot. But the latest recommendations in 2022 mention that NOACs are a reasonable alternative to vitamin K antagonist in post-MI with clot. What about patients with aortic stenosis who undergo TAVR, transcatheter implantation of valve with atrial fibrillation? NOACs are preferred over vitamin K antagonists. So the next thing is how to switch. Somebody is on one drug, we have to change to the other drug. So what is the strategy? If somebody is on vitamin K antagonist or warfarin, you listen to this talk, next week you see a patient, you think, okay, I want to change it to NOAC. So how do you start? So check the INR. If the INR is less than 2, we can start the NOAC immediately. If it is between 2 to 2.5, wait for 1 day. If it is 2.5 to 3, we should recheck INR after 2 days. If the INR is more than 3, don't start NOAC at that time. We can do it at review. If somebody is on NOAC and we want to change to vitamin K antagonist, patient is telling that I cannot afford or I want to change. So we can continue NOAC and start the vitamin K antagonist along with the NOAC simultaneously, and we can check the INR 3 days later, even though there are limitations for that. And once the INR is in the therapeutic range, we can stop the NOAC. Somebody is on unfractionated heparin, you are treating as inpatient, you are planning to discharge, going to change to NOAC. So when do you start? We can start the NOAC around 6 hours after the last dose of NOAC. Somebody is on NOAC, you are admitting, or you want to change to unfractionated heparin. The unfractionated heparin should be started 12 to 24 hours after the last dose of NOAC. Now somebody is on this one of these NOACs going for a surgical procedure, how to manage? So people may come for fitness and all. So if we have to think about the procedure, whether it is minor like a dental extraction or cataract, low risk like an endoscopy with biopsy or a PCI, or a high risk like a major surgical procedure. Usually if the procedure is a low risk procedure and normal renal function is there, 1 day gap is enough. If it is a high risk procedure, 2 day gap is required. Similarly, when there is abnormal renal function, 2 day gap may be required. And if there is a abnormal renal function with a high risk procedure, we may have to stop it for 3 to 4 days. And once after the procedure, if it is a low risk procedure, we can start 1 day later. If it is a high risk procedure, we have to start 2 to 3 days later. Remember that there is no recommendation for perioperative bridging with heparin with NOAC. Now, after stroke, somebody has AF and a stroke. If it is a TIA without any imaging abnormality, we can start NOAC on the next day. Mild stroke after 3 days, moderate stroke after 1 week, and severe stroke, we should not start anticoagulation immediately. Should be started only after 2 weeks after repeat imaging and ruling out hemorrhagic transformation. Now, we have to liberally use proton pump inhibitors, especially if they are elderly, high bleeding risk, and concomitant antiplatelet therapy. Alcohol and NOAC is not a good combination due to multiple reasons, including propensity for fall. In pediatric use, NOACs have now been recommended. Apixaban, if the weight is more than 40, we can use in the same dose. If it is less than 40, we have to modify the dose. For COVID in-hospital prophylaxis, we know 2.5 milligram twice daily apixaban and rivaroxaban 10 milligram OD was used. And the Kerala government also recommended using rivaroxaban and apixaban during the pandemic. So just for the sake of the postgraduates, the names of the antidotes for NOAC: idarosizumab is the antidote for dabigatran, andexanet alpha is for factor 10A inhibitors, and siraparendac is a universal antidote for all these agents. So beyond antidotes, activated charcoal given early can be useful for dabigatran and apixaban, and dabigatran is hemodialysable, so in acute situations we may use this. Very, very important when not to use. Don't use NOACs in patients with mechanical prosthetic valves, in patients with rheumatic heart disease, mitral stenosis, atrial fibrillation, and in patients with creatinine clearance less than 15. All NOACs are currently contraindicated in pregnancy and in women planning a pregnancy. So young females, before prescribing, be careful, even though some data is coming. Now, one of the Achilles heel for the NOAC is APLA, where vitamin K antagonists are still preferred over NOACs, especially in arterial thrombosis related to APLA. Also, in chronic thromboembolic PH, probably vitamin K antagonists may be better. So, to conclude with some perspective, we know that there is no need for monitoring, but is it like a double-blind study? How do we know that it works? There are effects on the coagulation assay which may not actually reflect the anticoagulant activity. We also have to consider the cost of health, but with now more molecules, more companies being there, maybe approximately 800 to 900 rupees per month, we can give an adequate anticoagulation. So cost effectiveness is there. Recently, there was some bad news about rivaroxaban regarding the validity of the trial results. And in rheumatic heart disease, AF, one of the authors of this article is from India, from Aldia Institute. And in RHD with AF, NOACs still should not be used. So we have dealt with the major questions regarding NOACs. But in the OP, when we see a patient, Malappuram Katti mudal ultra modern machine gun vare now we have. So how do you choose? It's a very difficult path. We have to balance the thrombosis and the bleeding risk, take the patient as an individual person and look at the clinical scenario. What is the treatment plan? Am I planning any procedure? Is the patient being treated in the OP or in the ICU or in the outpatient? What is the renal hepatic function, baseline coagulation and platelet, and the bleeding risk? Very, very important. Of course, there are physician-related variables and also environmental factors like economics and compliance, and also in some particular small corner of our mind, a bystander equation and medico-legal issues also should be considered in these difficult times that we practice medicine. But ultimately, in a patient, in a confusing situation, the most important question is how you would treat yourself or someone in your family if we have an indication for anticoagulation. That will give us clear answers rather than many of the things that we read on literature. And we should also, as doctors, as scientists, we must have the humility to remember that what is best practice today may not be the best tomorrow. The science is evolving. And please don't criticize prescriptions when you see another doctor writing, this is not the right dose or the right molecule. The science is evolving and we try to learn. Thank you so much. And Nanbagal Neratha Mayangade Ketadine, thank you. Thank you so much to the Thrissur team for this invitation.
Thank you, Dr. Sajan. It was an excellent presentation. I think you have covered almost everything. There is nothing, no point is left. Anyway, even though bleeding is a risk, is bleeding created any problem in patients with NOACs in your personal experience, and how do you tackle? Many times these antidotes may not available in our hospitals.
When these NOACs were actually launched, the initial criticism was vitamin K antagonists have antidote. We have vitamin K. These don't have antidotes. That was a major issue. But I think all of us will agree that over all these years that we have used, we have never had to use an antidote, thankfully, touch wood. But at the same time, as cardiologists, when we prescribe, we also have to remember that we may be missing bleeds. Because all the patients who bleed may not come back to us. Patients may be going to the neurologist or the gastroenterologist or the urologist. So we may be missing some bleeds also. But overall, with all the data and in the clinical practice that we have, they are really safe. I mean, only thing is we have to choose the right molecule for the patient and use it in the right dose and keep the patient under follow-up. In between, monitor hemoglobin, look for occult blood loss in particular situations. So if we take care, I think they can be really good molecules. It is actually revolutionized management. You see somebody in the OP with an AF or flutter or something, it makes it so much easy to treat. So,
the vascular dosage of rivaroxaban is twice daily. One is a truly once daily drug.
Correct, sir.
What is the idea behind that?
Question. I also looked into it. I talked to one of the investigators also. In fact, for AF and thromboembolism and everything, we use once daily preparation. But for the peripheral arterial disease and CAD, we use twice daily. The explanation that we got is that the 2.5 milligram twice daily, to reach a steady state level which maintains the anticoagulation, it has to be given twice daily. But for the higher dose, that level is maintained for 24 hours. That is the pharmacokinetic profile of the drug.
It was a nice talk. Thanks, Sajan.
Thank you.
Enlightened.
Thank you, everyone.